Every single minute, 4 women somewhere in the world are being diagnosed with breast cancer. 1 in every 20 women will face this diagnosis in their lifetime. For decades, breast cancer surgery often meant big incisions, long recovery, and scars that can change how you feel in your own body. But a newer approach is changing how surgeons can have access to affected tissues, and in some cases, it can mean a much smaller cut. Today, I'll explain what robotic breast cancer surgery is, who it might be for, and what the real trade-offs are. Stay with me. Whether this affects you directly or someone you love, this information could benefit someone. Let's start with the data, because understanding the scale of this disease is the first step to fighting it. According to the International Agency for Research on Cancer, the IARC, approximately 2.3 million new breast cancer cases were diagnosed worldwide in 2022 alone. And projections published in February 2025 in the journal Nature Medicine warn that if current trends hold, we're looking at 3.2 million new cases per year by 2050. Breast cancer is the most commonly diagnosed cancer in women globally, and the second most common cancer overall. The message here is crystal clear. Early detection saves lives. A 99% survival rate versus 30%, that gap is not a coincidence. It's the result of catching the disease early. And here's a stat that should concern all of us. In high-income countries like the US and France, about 1 in 10 women will be diagnosed in their lifetime. But in lower-income countries, more than half of women diagnosed will die from it, not because the cancer is worse, but because access to screening and treatment is limited. Which brings us to the most powerful tool we have right now: prevention and early detection. Now, here's the empowering part. Because we are not powerless against breast cancer. There are 3 major screening tools that can detect cancer early when it's most treatable. The mammogram is still the gold standard for breast cancer screening. It uses low-dose X-ray to create images of your breast tissue, and it can detect tumors up to 2 years before they can be felt by hand. Current guidelines from major medical organizations recommend annual mammograms starting at age 40 for women of average risk. If you have a family history of breast cancer, your doctor may recommend starting at 30 or even earlier. Yes, there's mild discomfort, and yes, a few minutes of pressure is absolutely worth the peace of mind. Ultrasound uses sound waves, no radiation, to produce images of breast tissue. It's particularly valuable for women with dense breasts, where mammograms can sometimes miss tumors hiding in that dense tissue. Ultrasound is also often used to follow up on something spotted in a mammogram. It helps distinguish between a fluid-filled cyst, usually harmless, and a solid mass that may need further investigation. It's painless, quick, and can be done right alongside your mammogram. MRI, magnetic resonance imaging, is the most sensitive screening tool we have. It uses magnetic fields and radio waves to produce detailed 3D images of breast tissue and can detect cancers that mammograms and ultrasound might miss. Breast MRI is typically recommended for women at high risk, specifically those with BRCA1 or BRCA2 gene mutations, a strong family history of breast cancer, or those who've already had chest radiation therapy. It's more expensive and not typically routine for the general population, but for high-risk women, it can be life-saving. Now let's talk about surgery, because when breast cancer is diagnosed, especially in stages 1 through 3, surgery is usually part of the treatment plan. Traditionally, there have been 2 main surgical options: a lumpectomy, where only the tumor and a small margin of surrounding tissue are removed, and a mastectomy, where the entire breast is removed. For many women, especially those with larger tumors or genetic risk factors, a mastectomy is the recommended path. And for decades, the standard mastectomy meant a large incision across the front of the breast, or even the chest wall. Traditional mastectomy, the realities. Decades of proven oncologic outcomes, widely available at most hospitals, surgeon familiarity, lower learning curve. lower cost to the healthcare system, shorter total operative time, large visible scars, significant psychological impact, complete and permanent loss of nipple or breast sensation, higher risk of post-operative lymphedema, arm swelling, greater blood loss during surgery, harder to preserve nipple areolar complex, longer recovery, typically 4 to 6 weeks before returning to daily activities, physical restrictions, arm movement, lifting. For many women, the traditional mastectomy was, and still is, a valid, life-saving surgery. But the psychological and physical toll is real. Studies show that losing a breast, especially with a disfiguring scar, significantly impacts body image, sexual well-being, and mental health. That's exactly why the surgical community began asking, is there a better way? Enter the Da Vinci single-port robotic surgical system. This is one of the most exciting developments in breast cancer treatment in decades. Here's how it works. Instead of making a large incision across the chest, the robotic surgeon creates one small, hidden incision, often less than 2.5 centimeters, tucked in the armpit or along a natural skin fold where a scar is virtually invisible. Through that tiny opening, a robotic arm equipped with a high-definition 3D camera and 4 miniature surgical instruments enters and removes all the breast tissue from the inside while completely preserving the nipple, areola, and overlying skin. The surgeon sits at a console, think of it like a flight simulator, controlling every movement with precision that surpasses human hands. The robot eliminates hand tremor, provides 10 times magnified 3D vision, and can maneuver in spaces the human hand simply cannot reach. This procedure is called the Robotic Nipple-Sparing Mastectomy, or RNSM, and it was first described by Italian surgeon Dr. Beniamino Bianchi in 2015. In 2018, only 3 centers in the world were performing it: hospitals in Paris, Milan, and Seoul. Today, it's being performed at leading centers across the United States, South Korea, Taiwan, Italy, France, and other countries, and the results are remarkable. In January 2024, UT Southwestern Medical Center in Dallas, the institution that performed the first single-port robotic nipple-sparing mastectomy in the US, published a 4-year study in JAMA Surgery showing that this approach is not only safe and feasible, but approximately 80% of patients retained some or all breast sensation after the procedure. 80%. For comparison, traditional mastectomy typically results in complete permanent sensation loss. Let's put these two approaches side by side so you can see exactly what the difference means for a patient. Recovery time is similar, but incision in traditional mastectomy is around 15 centimeters across chest, while robotic incision is around 2.5 centimeters. Blood loss in traditional surgery is significantly higher, and it leaves permanent loss of sensation. Robotic preserves it in 80% of the cases. However, robotic surgery isn't for everyone. The FDA has issued guidance that robotic-assisted mastectomy should still be considered in the research phase for many applications, and we're still waiting on the long-term 5- and 10-year oncologic safety data from major randomized trials. But early results are genuinely exciting, and for the right patient, this could be transformative. So, who is a candidate for robotic nipple-sparing mastectomy and where could it be accessed? Women with stage 0 to stage 3, A breast cancer. Women with BRCA1 or BRCA2, mutation-seeking prophylactic, preventive, mastectomy. Patients with smaller to moderate breast size with limited sagging. Cases where tumor is not located close to or involving the nipple areolar complex, no planned chest wall radiation, which affects reconstruction outcomes, and women wishing immediate breast reconstruction at time of mastectomy. The leading centers performing robotic nipple-sparing mastectomy are located in countries like United States, Italy, Taiwan, and France. If you're interested in exploring this option, search for NCI-designated cancer centers in the US, or ask your doctor about referrals to institutions with robotic mastectomy programs. We've come so far. When my grandmother's generation faced breast cancer, treatment was brutal and disfiguring. Nowadays, we have screening tools that catch cancer before we can feel it, and surgical techniques so precise they can remove an entire breast through an incision smaller than a bottle cap, while preserving the nipple, the shape, and in 80% of cases, the feeling. The robotic approach isn't the answer for everyone. It's still being studied. It requires specialized surgeons and specialized equipment, and it costs more. But it represents something remarkable: medicine that treats cancer and respects the whole person. The future of breast cancer care is happening, is more precise, less invasive, and more human. If this video helped you, please hit like, subscribe, and share it with the women in your life. Drop a comment below. Has anyone in your life experienced a mastectomy? Would robotic surgery have made a difference? Let's talk about it, and I'll see you in the next video.